So I think we're all going to talk from the perspective of case studies, and mine is particularly involving the implanted cardiac monitor, and it's something that has commonly been called an implanted loop recorder. It's probably the more modern name for it, and that's what it looks like. So it is truly the size of a AAA battery. It's very small, and it's a very powerful piece of technology. And so I want to talk through the perspective of questioning a long-held diagnosis. And what I mean by that is many diagnoses get into a patient's problem list over years, and no one tends to think too much about it. They just believe the person has what they have. And so here's a great example of a patient that had a diagnosis of epilepsy for 20 years, and this is the referral letter from the neurologist. So Gary had a diagnosis of epilepsy on the basis of a few collapses. The events were not associated with a post-ictal period, and he's had recent normal EEG and MRI. He is having side effects of valproate. He had been on valproate for 20 years. He has had palpitations, sometimes heart racing, sometimes skipped beats, missing beats, and he has had to sit down during exercise. So now I guess you can forgive the neurologist 20 years ago for not being able to advance beyond that sort of a diagnosis. But the modern way to deal with that sort of patient is to use new technology, and so in September last year, he was implanted with a cardiac monitor. And it wasn't very long until some interesting information came out of it, and this is some of the interesting tracings. So it was only 2 months after it had been in that this man transmitted a 7-hour episode of atrial fibrillation. He wasn't really aware of palpitations, he just felt unwell. And so you can see that tracing there shows an irregular heartbeat. And up the top, I'm not sure if... Yeah, up the top, this is called the dot plot, which is common in device interrogations. And if you've got a regular heartbeat, all those dots will be in a line. But if you've got an irregular heartbeat, like atrial fibrillation, the dots will be random. So, and down the bottom, you can see the burden of atrial fibrillation. This is the line of implant. That was the day the device was implanted in September. And he's had no arrhythmia until he gets to this point, and this crosses over midnight, so there's a 4-hour and a 3-hour episode of atrial fibrillation, or it's in that AT/AF, atrial tachycardia/atrial fibrillation graph. And a little bit more time went on. He never had any more atrial fibrillation, but he started transmitting other heart rhythms. So another tachycardia episode. Here we have a line of tachycardia. So if you look on this axis here, this is heart rate. So here's a heart rate of about 60, 70 beats a minute, normal rhythm, and then suddenly a heart rate that jumps up to about 200 beats a minute. Only goes for 6 seconds in this case, and then it jumps back down to 60 beats a minute, and the ECG tracing that corresponds to that is normal rhythm, jumping to tachycardia, and then suddenly going back to normal rhythm. So this is a typical supraventricular tachycardia. And he started transmitting quite a few of those sorts of episodes. And then in February this year, he transmitted the opposite. So here we have a heart going at about 80 beats a minute, and then suddenly dropping down somewhere below 10 beats a minute, and back up to about 100 beats a minute. This is the ECG tracing from that event. And here we have normal rhythm, and then an 8-second pause, a ventricular escape beat, back to normal rhythm. Now, this might be common in a vasovagal attack, but this person had no particular trigger. He was just standing at a sink, filling up a drink bottle, and then suddenly he's trying to grab onto the side of the sink, just about blacked out. And he said an interesting thing. He said, that felt like all my seizures over the last 20 years. So to summarise what the device has found in only 3 months, He's got paroxysmal atrial fibrillation, supraventricular tachycardia, and transient complete heart block. Before I tell you what I did next, I might just ask the panel, can you link these three things together in any way, guys? Are they totally unrelated? Is there some single diagnosis that explains it all?
Well, I don't know. Are these on? I'm not sure if these are on or not, but...
No, I don't think they're on.
Can you hear?
Yep.
So I think this gentleman's developing what we'd call the six-liner syndrome or the bradytachy syndrome, where they can alternate between atrial fibrillation, bursts of rapid arrhythmias, but then interpaused with slowing rhythms. But this may not be his problem all along. I think that the real issue here is that he's had 20 years of syncope or epilepsy, and we've documented symptoms at the time of pauses. So he's probably had these pauses all his life, and I suspect that if you paced him, you may well cure his epilepsy and eliminate the need for the anticonvulsants.
Okay, so what would you do next? Would you just put in a pacemaker? Would you do an electrophysiology study? Yep.
I think it would depend a little bit on the patient. It seems to me like the arrhythmias are a recent onset, as in the atrial fibrillation. That may not have been a long-standing problem. I think probably that his symptoms over the years are due to the pauses. I think it would be a reasonable option to pace, eliminate the pauses, and consider some antiarrhythmic agents, which you can now more safely use once he's paced, because they're not going to aggravate a bradyarrhythmia.
Thanks, John. I actually went the other way. I did an electrophysiology study first because I thought, well, maybe there's some AV nodal interaction that might be causing transient AV node block and also SVT involving the AV node, but I didn't find that. He actually had a concealed accessory pathway on the left side. And interestingly, that's a known trigger for atrial fibrillation as well. So if you see where that pathway is entering the left atrium, if you can imagine that there's some concealed penetration of conduction going up that pathway, then it sets up the left atrium for a trigger for atrial fibrillation. So I'll be fascinated to see over the next few years whether he gets any more atrial fibrillation now that his accessory pathway has been ablated. And since he was getting transient complete heart block and it seemed in no way related to the SVT, I also put in a pacemaker, and then the neurologist came along and stopped the Tegretol, or the valproate. So it was a fascinating case, and probably we've fixed him, and we'll just have to wait and see. But we'll be keeping that monitor in for another 3 years because it's got that much battery life in it, so we'll find out. And so take-home messages from this talk are to keep an open mind into a patient's history, and sometimes question what's on the medical history list. And then I just wanted to demonstrate how powerful these implanted cardiac monitors are these days in recording these sorts of rhythm problems and getting to the bottom of a diagnosis. Thank you. End of my case. Should we ask questions? Keep rolling through. Anyone have any questions on an implanted cardiac monitor and what its indications are? Everyone familiar with the technology? It's been around for about 3 years now, that device. Yep. The indication is recurrent syncope. It's something, if you meet those indications, it's fully covered in the private hospital by health funds. And the public sector uses very much the same indication to put them in. So out of pocket, an uninsured patient in the private sector would have to pay around $4,000. It's come down from $6,000 over the last 2 years. And but if they meet health fund criteria, it's fully reimbursed, and it doesn't cost the patient anything, obviously, in the public sector either. Just you might need to wait a bit longer to get it put in. Okay, thanks. Keeping moving. Oh, one more question? Are they an inflammation risk? A cremation risk. It probably, yeah, it probably is the party line from Medtronic is yes, they need to be removed. It's probably debatable whether they do a lot of damage